Okay, let's see. Here's the first one, and I want you to look at the 12 lead, see if you see anything notable. So just spend a minute just kind of looking. Okay, then look at after you look at the 12 lead, see if you see anything. Then look at the description of the patient and see if you can see, is there something that's a little weird in terms of matching up the 12 lead with the description of the patient? Is there something that doesn't quite fit? Nava, what do you think?
I was thinking path Qs and V1, 2, and 3.
Excellent, okay.
I think old STEMI, but he says no history.
Okay, so everybody see that? The pathologic cues in V1, V2, and V3. And Grace, pathological cues in V1, V2, V3, what do those suggest?
Old infarct.
What kind of an infarct?
Posterior. No. Sorry.
Wake up. Yeah, septal anterior, okay.
Jesus.
And, no, it's okay, it's first minute. Okay, but he has no history of heart disease. So it's possible that he's, sometimes people do have heart attacks, do have MIs, and they don't know, so that's a possibility. It's a little weird though, he's only 44, he came in because of the fall, and so forth. So what is, and I wouldn't expect you to know this, but maybe you do, is what's another explanation for this? Anybody know? No? No, it's something so much more simple. So here is a 12 lead that was taken 14 minutes later. What's the difference? Look at those V leads. Q's are gone, right? Because now all of a sudden it's not a Q anyway because there's some R waves poking up. So those aren't, maybe there's a Q here, but V1 is always so squirrely because there rarely is an R at all, but certainly there's no Q's in V2 and V3. The difference was how the electrodes were placed, okay? And so what happened was that the original one that showed the Q's, V1 and V2 were placed too high. They were up, they were up above where they should be. And what was kind of interesting about this, I have no idea if anybody's bumped into this because I've never heard it from another student, but a few years ago, there was a student who was in clinicals and said, the nurses don't place and I don't know where they were. I had no idea if it was all the nurses, one nurse, whatever. But the nurses place the electrodes a little different, and they place V1 and V2 too high. And I was like, I don't know. I have no idea why they would do that. And then I kind of went looking to see if there was, because I'd never heard of that, if there was an alternate placement, and bumped into this case. So no, there's not an alternate correct placement, but I thought this was kind of interesting. Okay, let's look at the next one. Okay, so look at it for a little bit, and then some brave person jump in and tell us what's happening on this 12 lead. So, Kyle, there's a handout in the back. You'll see it. Now, I'll give you a hint here, is the key to understanding this particular 12 lead is knowing what the rhythm is first. Okay, so what's the rhythm? Pretend this was just an ECG class. What is it? With what?
Bigeminal PVCs.
Okay, so it's a sinus rhythm with bigeminal PVCs, right? And then something goofy happens here. I'm not quite sure what. So you can see, here's the sinus beat. here's the PVC, sinus, PVC, and so forth. Okay, everybody see that? Like, you wouldn't have any trouble if we were doing this in the fall, and I just gave you a strip, every one of you would get that, okay? Now, the thing about, well, actually, it doesn't show here. So when we're looking for ST elevation or ST depression, do you look at the sinus beats, the PVCs, or both? Say it again? Yeah, just the sinus beats. So ventricular beats, whether they're PVCs or VTAC or you know, AIVR or whatever, will almost always have either ST elevation or ST depression. They always do. It's part, and it doesn't count. It doesn't count for an MI. It's just part of their pattern. So for example, here, this PVC and these PVCs all have ST depression, okay? Doesn't mean that there's ST depression in lead 3. It's because it's a ventricular beat. And I'm sure at this point you can all picture, remember we talk about some ventricular beats are mostly positive with so mostly, or in this case, all positive with a flipped T. Those are the ones that have ST depression. Then picture in your mind the mirror image or the flipped image where the QRS is mostly negative. Then what's going to happen is the T wave will be upright and there's always ST elevation. It's part of the ventricular pattern, so it doesn't count, okay? You know, another way of saying it is if you have a ventricular rhythm, you can't tell whether there's a STEMI. I mean, if the whole thing is ventricular rhythm, for that reason. So, in this case, what I would do is just circle the sinus beats, and now you can say something about what you're seeing. So is there a STEMI, and if so, where is it? Okay, cool, where is it?
I see ST elevation in inferior leads of 2, 3 in AVF, and then some depression in AVL for reciprocal strings.
Correct, and there appears to be something happening in 5 and 6, maybe there's some lateral, but it's really hard, like the pattern changes, something goofy is happening here. So I don't feel confident from this 12 lead in talking about those lateral. Possibly there's going to be a posterior, we see a tiny bit of ST depression here, but this would be one very helpful to run off a couple more 12 leads so we at least get more sinus beats to look at, okay? There's no question, as Koa said, we have the inferior STEMI with ST depression in the high lateral, okay? So just a good rule of thumb, whenever you're analyzing any 12 lead, if there are ventricular ectopic beats, ignore them. They're going to confuse you, okay? So you can scribble them out, put a piece of paper, cover, I mean, whatever, just ignore them. Okay, so, there we go. Okay, so today we're really going to be talking about signs of ischemia. The second half of the lecture, this is kind of a huge lecture, probably we won't even get to until spring, which are the conditions that mimic an acute MI. But today what we're going to do is to kind of do part review, part more in-depth study of some of the signs of ischemia. So what we've done prior to this is we've looked at signs of ischemia like, Cody, do you have your hand raised?
Yeah.
Okay.
Is this on cameras?
Is it not there?
I don't see it unless
Okay.
I'm missing
It could be that I've didn't. Let me open it up. It's you know what? It's T waves. Signs of that's right.
it. Thank you.
Okay. Yeah, there we go. No, thanks for asking. Okay. So what we've done in the past is we've looked at everything through the lens of a STEMI. Okay. So we've already talked about hyperacute T waves, but we've done it through the eyes of a STEMI. Now we're going to kind of reverse it and say, well, let's forget about the STEMI for a minute. What about just those T wave signs that are significant? So there's going to be a little bit of overlap here, which I always think is not a bad thing because these are difficult concepts and you know, if you get bored, you can check your email, but I think the repetition is not a bad thing. And plus, we're going deeper, okay? So, important note. So, okay, so while clinical presentation, everybody knows what I mean by clinical presentation, right? Like how the patient is appearing. It's always important. It's always important. But it's more true if the ECG signs are subtle. So for example, if this is your patient's 12 lead, I don't care if they're sitting there doing jumping jacks saying, I feel fine. You're going to, you know, do a STEMI alert and get them in. I mean, it's like, in this one, clinical presentation is less important. Just make sure they're breathing and get going, you know. But what we're talking about today are where maybe there's a STEMI and maybe not, but either way, the signs are very subtle, okay? And in that case, clinical presentation becomes more important because we're trying to figure out what's happening here. Okay, some of the more subtle signs of possible ischemia, blah, 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 blah. So some of the signs we're going to be talking about, such as T-wave changes, can also happen with other underlying conditions, okay? So that's why in this case we want to say, okay, is their presentation consistent with ACS? Now, the signs of ischemia, of acute, here are possible signs of acute ischemia, and we've really talked a lot about ST elevation in the setting of a STEMI, so we're not going to be talking about ST elevation. And the truth is, we probably won't get far enough to get to ST depression, so we'll do that next time. But what we're going to be talking about, and it might take all day, we'll see how it goes, T-wave changes, okay? So, what have we learned about normal T waves? Let's say in lead 2. What does a normal T wave look like? What did we talk about in the fall? What did we say? That was all lead 2 stuff. What does a normal T wave look like? Yeah, and in the fall I just emphasized upright. I said some of the other things we'll get to, but all we care about is upright. And that's still true. It's upright. So the other thing about T waves is normal T waves are asymmetrical. And they're asymmetrical in a very particular way. So what happens is the upslope is flatter than the downstroke. Okay? Does that make sense? The slope here is a little bit less steep, and then it sort of falls off the cliff here, okay, as opposed to symmetrical. Now, sometimes it's hard to see because we have ST elevation or depression, and then if you're interested in finding out, you actually just need to, you know, really extend the line with a straight edge or, you know, draw it down to see what it's like. And it's true, even, and this one actually is wrong because it should be like that. It's true even upside down. It should be asymmetrical. That being said, let me go back this because that doesn't make a lot of sense there. That being said, even though I say this and everybody's carefully writing it down as you should, I find this less useful than you would think. And the reason is it's hard to see. You think, no, I can see asymmetry. It's really hard to see. It's really subtle. I know that I've been looking for a long time, and sometimes I'll sort of test myself and I'll say symmetrical, asymmetrical, and the way to really find out is to sit there and really kind of use a ruler and say, well, is it, and you know, I'm wrong a bunch of times, and I've noticed with people who are just learning, such as yourselves, that you know, they'll say, oh, that's symmetrical or asymmetrical, and I look at it and say, that's not, you know, so you should know this, but it's less useful than you think, just because it's hard to see. Okay. So normal T waves are upright in all leads except V1 and AVR, where they typically are inverted. And we can say inverted, flipped, it's the same thing. okay? Upside down, whatever. Now, again, that sounds like a great sign, T-wave inversions, and in fact, in a minute, I'm going to tell you why that's not going to be quite so useful as you think. T-wave inversions due to myocardial ischemia or infarction may occur in contiguous leads along with ST elevation. Okay, so sometimes when you'll look at what's the progression of a STEMI, you'll see that they will include inverted T waves, because sometimes that does happen. So, for example, here, so Grace, there is a STEMI here. What area is it in?
Lateral,
Uh-huh. And how do you know?
because there's elevation in one in ABL, so high lateral.
And what else?
And depression in 2, 3 in ABL.
Yeah, so we've got reciprocal changes. And lo and behold, in the area of infarction, we have inverted T waves. We also have inverted T waves, if you notice, in the other lateral leads, we don't quite have ST elevation here, but we do have inverted T waves, and also in V4, suggesting something may be happening here. Is there a hand in the back row, Cody?
That's what I was just gonna say. I thought I saw some elevation in V5.
You know,
Slightly.
it's very, very slight. It's not a full millimeter, but you're right, it has that, it just looks like it's going to happen, and the T-wave inversion is also suggestive that something's going to happen. Now, inverted T-waves due to ischemia, and here's one of the problems with using inverted T-waves as a good sign of ischemia. In fact, I don't think inverted T-waves are a good sign of ischemia, a useful sign. They're a good sign, but not a useful sign, because they're kind of like Q waves. They can be dynamic, seen with acute myocardial ischemia. So really, if you do a 12 lead and then 10 minutes later do another 12 lead, and all of a sudden the T waves are inverted, now that's useful. That's saying something is happening, very possibly ischemia in whatever the leads are, okay? But the problem is they're like Q waves. They tend to hang out. Like if you do a 12 lead 10 years later, those inverted T waves may still be there, telling you, well, an inverted T wave by itself with nothing else is not necessarily useful for what's happening today. Make sense? Kind of just like Q waves. So for example, this person had an old anterior STEMI, and we see all the septal anterior STEMI, and we see all the Q waves. We also see inverted T waves. And probably if we, do another 12 lead in 6 months, it's all going to still be there. So in this case, it's not so useful. The other reason why inverted T waves by themselves, with one exception that I'm going to tell you, are not that useful is they tend to happen for a lot of different reasons, not just ischemia. So normal in kids, bundle branch block, ventricular hypertrophy, pulmonary embolism, raised intracranial pressure can all cause T waves to flip. And so you can't look at it and say, oh, must be a STEMI. Who knows? It could be pulmonary embolism. Okay? So for that reason, they're not so useful. And in fact, T waves are, the phrase that you might bump into is that they're labile. Now, labile is a word that perhaps you use in regular conversation. If you describe a person as labile, it means they're moody, okay? It means that their mood shifts easily. Somebody who, sort of a dramatic kind of person. And that's what we say about T waves, is they tend to respond, they're very dramatic, they tend to respond to a lot of different conditions by flipping, which makes them less than useful for us. So, bottom line, not all T waves are useful, changes are useful, but there are several that are worth memorizing, okay? The first one we've talked about, but we're going to expand on it today, and that's hyperacute T waves. The next is the one case where I say you really should pay attention to inverted T's, and that's a very specific thing called Wellens syndrome that we're going to look at. And then we're just going to dip into hyperkalemia T waves a little bit. Okay? So, we're going to start with hyperacute T waves. And who remembers, what does that term hyperacute actually mean?
Over 6 millimeters from the J point. So
What does the term hyperacute mean, regardless of whether it's with T waves or just used in a sentence?
Very large.
Nope.
That was quick.
Say it again?
Quick.
Yes. Very quick, very soon. So hyper, you're exactly right, Chris. This is what, by the way, you're in such good company. 9 out of 10 people would say very large, because that's what we think. So hyper, of course, means big, but what does acute mean? Means now, means soon. So that it's like hyper now. It's like early sign. Another way to say it is the very early signs. Hyper early. That's what hyperacute means. Now, as we've said, hyperacute T waves, and this is old news, but we're going to add on it. Okay, so you've seen this before, and you've probably seen this or something else like it in the previous lecture, where we say, oh, so this is 15 minutes after onset of chest pain, maybe a tiny bit of ST elevation, but a great big fat bulky T wave. And then as time goes by, this is no longer considered a hyperacute T wave, because remember we measure from the J point, so it no longer fits our definition, but we've got plenty of ST elevation. Now, hyperacute T waves is a funny thing. There's actually not, even though we talk about them a lot, and we're going to talk about them a lot today, there isn't like this official definition. People use it for different things. We've learned one version, but there actually are 3 versions of hyperacute T waves, okay? So the first one we've already done. Tall, bulky, greater than 6 in the limb leads, just as you said, greater than 10 in the precordials. It's measured from the J point. And we've, I probably showed you this before. We can see the hyperacutes in the septal anterior leads. And then in the precordials, they need to be greater than 6. We've seen that too. But here's a second way to describe hyperacute T waves. It also has to do with the size of the T wave, but the relative size of the T wave. Before we were saying absolute size, greater than 6, greater than 10. But probably more important, a little more up-to-date way of looking at it is relative size of the T waves. How does the size of the T wave relate to its QRS, okay? So even more important than the actual size is its size relative to the QRS complex. So ask yourself, can the entire QRS complex fit inside the T wave? So what am I talking about here? So by our new definition, or our additional definition, we're not forgetting the old one, that still counts. We're adding another way to look at T waves. We have hyperacutes in 3 and AVF, and actually those actually fit the old definition too. But if you were to take that QRS, what we're asking ourselves now is a slightly different thing, not the absolute size of the T waves, but if we were to take that QRS, could we move it take the QRS and put it inside the T wave, would it fit? And you could see, or close to, it doesn't have to be, these aren't absolute precise, but you can see that the amplitude of the T wave is larger, is taller than the amplitude of the entire QRS. And that's a bad sign, okay? Now, where else on this 12 lead can you see where the size of the QRS, the entire QRS, can fit inside the T wave?
AVF.
Excuse me?
AVF.
AVF, correct, and which other leads? It's on the slide, but you can find it by looking. Where? Oh, I guess you're right. Yeah, I hadn't thought of it there, but there, yeah, I'll say that. Where else? Where else do you see little tiny QRS complexes relative to the size of the T wave? Even if the T wave isn't great giant. Yeah. See how small this QRS is? You could take that and stick it, the height of it, the amplitude is less than the amplitude of the T wave. Same thing here, same thing here. So we don't yet, I think we don't quite have a lateral STEMI, but based on this, remember hyperacute is early, okay? And so if you look at those lateral leads, that's a very good indication that the lateral STEMI is developing, okay? Is this enough by itself for cath lab criteria? Probably not. I think I have it blown up. Here we go. Okay, so here we are. So this isn't enough for, there's a little bit of ST elevation here, but not so much here. But these are almost certainly hyperacute T's, meaning it's coming. Meaning if you did a 12 lead in, say, 10, 15 minutes, that ST elevation would probably have spread into these leads. Okay, so that's the significance. The other thing, by now, I'm hoping that you're starting to recognize this pattern, the really common one, okay? Inferior STEMI with lateral involvement and possible posterior, okay? And that's usually, almost certainly it's because of an occlusion in the right coronary artery, and it's a pretty common pattern, okay? So questions, everybody understand what you're looking for here? Okay. Now we've looked at the next 12 lead before, but we're going to look at it now with our new definition. So I showed this one before when we were talking about the 6 millimeter, 10 millimeter definition. And what we said, so we're just looking at the V leads, what we said is, well, there's one lead with ST elevation, so we don't quite have cath lab criteria, but we have all these enormous T waves. And what we pointed out before was V3, V4 maybe, and V5 by our old definition doesn't fit, okay? Because this isn't 10 millimeters. But if we use our new definition, well, this one easily moves into here, that one easily moves into here, and this one just about moves in. So now this is even more indicative, you know, again, before we were looking at the absolute amplitude of the T wave, but even more significant, to be honest, is the relative size. So let's look at how fast did these T waves develop. So this 12 lead was done 70 minutes after the onset of chest pain, okay? And we have ST elevation in V2. And now what we're going to look at is how did V2 develop, okay? What was its progression? We're going to look at 30 minutes after the onset of chest pain, then 45 minutes, then we're going to come back to 70 minutes of V2, okay? So this is what the patient looked like, or the V2, 30 minutes after the onset of chest pain. So you arrive, and you think, well, you know, if everything looked like V2, no problem, okay? And then 45 minutes, if you did a secondary, 12 lead on the en route to the hospital 15 minutes later, and you saw even a single lead change from here to here, you know, you should be hollering up to your partner, go faster, okay? Because this much change is really significant. And then 70 minutes, we see this. So this is what we're talking about. Okay?
Okay, so in pre-hospital settings,
Yes.
is there like an actual time or like a definition, like set time of like how many 12 leads we're taking, or we're just monitoring and just like,
Well,
waiting for changes?
here's how I feel about it. Is, okay, this is just my opinion, but I'm going to be showing you today, you know, next class, probably every class from now on, at least one, probably many more progressions of 12 leads. And some of them, you know, what I'm going to show you is here's the first one, here's the second. Sometimes it's 3 hours between it, sometimes it's 5 minutes, and the difference. So my feeling is this, is, you know, typically you put the 12 lead, you put the electrodes on scene, you do a 12 lead, right? And then you make your decision about where to go. What, unless you think there's absolutely nothing, I would leave, you know, unhook the V leads, but leave them on, don't pull them off. As soon as you get back into the ambulance, then plug them back in, then it's easier for us more than anybody else, you know, hospital people included, to do more 12 leads, because all you have to do is push. It pops it out. And in my experience, and we're going to see some pre-hospital 12 leads where people were transporting, what I found was, especially if you're doing serial ones where you're looking for the change, going down the road doesn't prevent you from getting a good picture of what's happening. Bumpy road, yes. When you're stopped, where, you know, once you stop, you know, like you get to the hospital and the ambulance is kind of juddering a little bit, that doesn't work either. But going down the road, no problem. So if you have something that's changing, it doesn't hurt the patient. Price of ink, who cares? It doesn't take, you know, even if you're doing other things, you just push it and it pops out. So I can't see, plus it's so interesting. I can see no reason not, if some things are happening, not to do, you know, in some cases every few minutes. Why not?
Okay.
So, yeah.
I know with at least the life packs, they will just automatically spit out 12
Okay, that's
leads
something-
when
yeah.
ST elevation changes or if the rhythm changes.
I would not, that's great, but I would not rely on that.
But
because
it just
we'll-
gives you, like, it printed out, so you're like, I should probably pay attention to it though.
Right, okay, well, thank you
Yeah.
for mentioning it, but it won't, I doubt very much it's gonna pick up the T-waves
Yes.
changes, yeah,
Yeah.
okay. More comments, questions?
Is that with just the 4 lead or the full 12? Just leave
With
it
the
at
full,
that?
once you have the 12 lead on, when the rhythm changes or you see drastic changes in like ST elevation,
Yeah.
It'll just automatically print it out.
Okay, so in your handout, and I can't remember exactly what I'm asking, for, number 1, 2, and 3, I think it's on there. It's probably asking if there's close to the 6 millimeter. But more to the point, you can take that QRS and just move it in, and the relative size is really significant, okay? So, and again, this is, I think, a really good use of both reciprocal changes and hyper-QTs, because yes, we have some ST elevation and 3 in AVF, but it's not the kind that jumps out and slaps you in the face. I mean, it's pretty subtle, but the reciprocal changes are not subtle and the T-wave changes are not subtle. So I would have no trouble calling this in as a inferior STEMI with possible posterior involvement. By the way, what is the, what's the rhythm? Yes, so Mobitz type 1, second degree type 1. So a good thing to know is that the inferior STEMI, the artery that feeds the AV node comes off of the right coronary artery. And so what you're going to, you know, it's an AV block, right? And so what you're going to see with inferior STEMIs, how should I say it? It's not unusual to see with an inferior STEMI an AV block. So first degree AV block, second degree type 1, and it's probably caused by the same event that's causing the STEMI. So just kind of a good thing to know. Okay, so Andrew, number 2, please.
I do not see any hyperacute viewers.
Yep, I agree. What about, boy, it looks big here. Why isn't that a hyperacute T?
Because the J point is up there.
Excellent. So there really are no hyperacute Ts here. The ST elevation is enormous, but the J point is here. And who knows, when it started out, if you went back in the progression of if that was possible to do, this may have been a hyperacute T, but it no longer counts. Okay, Cody, number 3, please.
I see it in V4 and potentially in V5.
Okay, excellent. And yeah, I agree with both of those. And what's the criteria you're using, the old, the new, or both?
That it fits inside.
Yeah, and also V4 fits both criteria. Excellent. What else? Any others?
I don't believe so.
V3.
I measured it.
Yeah, V3 by the old criteria, it definitely fits. And actually, if you look over at the inferior waves, you'll see that, remember, the old criteria, it has nothing to do with the relative size, which is what we've been talking about, but our old criteria is greater than 6 millimeters. So there actually are hyperacutes in the inferior leads as well. Okay. So this is one where we can look. I've got another 12 lead. So this is the original 3A, and this is 90 minutes later. And we can say, oh yeah, because we didn't actually have criteria for an anterior STEMI here, right? We didn't have ST elevation. All we had was these great big T waves. But you're in the back of the ambulance and you see those and you think, okay, I can't call a STEMI based on this, but we're going to, go to the right place and go there speedy. And sure enough, 90 minutes later, we've got it. The inferior, again, a little too early to call it, but let's see, did anything actually happen? It didn't really develop too much here. Maybe it might be coming. So,
On the top strip, would that be an end STEMI?
what was that?
Would that be an end STEMI?
Which one?
The top one?
The
The
top one.
non-ST elevation?
No.
line?
No, because there's no ST depression, which is, we look a lot for ST depression. It makes more sense to think of it as a developing STEMI with the hyperacute Ts. So hyperacute Ts, if that's what they are, will develop into ST elevation. Okay, so we've now got our first version, our second version, here's our third version. Now remember, these are kind of informal definitions. Just because nobody's really codified it, but they're useful to know. This one is I'm going to say it's the squirreliest because it depends on things changing and we don't always see things changing. But if you know this and are looking for it, it's very useful. Okay? At the very beginning of an ischemic event, possibly leading to a STEMI, the initial part of the T wave straightens out, okay? Let's go look at the next. No, let's keep looking here. So it's very hard here. We keep seeing this over and over and over again. When we first started off in the fall, we said, oh, here's the ST segment. Here's the J point, here's the ST segment, here's the T wave, right? And we've seen plenty of, ECGs like that. But what happens is as ischemia develops, that ST segment starts to tip up and it kind of merges into the T wave. And we're no longer able to say where does the T wave start and the ST segment end, which is why we use the J point for our point of elevation or depression, okay? But in this case, we're talking about that ST segment T wave part, how it becomes straight. So figure A shows an inferior lead before the onset of a STEMI, and D shows, oh, now we've got ST elevation, we've got our STEMI developing. How does it get from here to here? And if you see, the first thing that happens is the ST segment tips up and the T wave straightens out and it becomes flat, and then it eventually becomes concave meaning this way, and then the ST elevation starts. So if you know that fact, while you can't say, make do a STEMI alert or anything like that based on this, it's telling you these are areas we have to pay attention to. These are areas, if we do another 12 lead, we're going to look. Okay. So, Cody, where is the STEMI here?
elevation 2, 3, and ABF.
Okay,
Or elevation, did I say elevation?
Yeah.
Depression and AVL.
good.
Pathological cues in V1, V2, V3.
So I'm going to push back there. There may be in V1, but V1, if you just see pathologic cues in V1 and nothing else, it's meaningless because V1 so rarely has any R wave at all. This is not, it almost looks like a Q wave, but even that tiny little bit of an R wave means this is an S wave.
Okay, gotcha.
Okay.
So
Yeah.
scratch that one. Looks like the ST segment is sloping, starting to slope.
Uh-huh. Okay, so let's look. So we've got, no question here, STEMI alert, right? I mean, no problem there. But let's look at the V leads again. Remember, it's a common pattern for an inferior STEMI to eventually involve the lateral, and usually it's 5 and 6, okay? And if you see, we don't know for sure, but my guess would be if we did another 12 lead in some period of time, that we may start seeing ST elevation here. We don't know for sure because we don't know if this is useful, we don't know if this is acute. This could have been here for a while, but just seeing those straight T waves, it's worrisome, okay? Okay, so, and what about this one? So where do you have a STEMI, and then where do you have areas that don't quite have ST elevation but have things straightened out?
I think I see elevation in 2, 3, maybe.
Okay,
And then I think I see some straightening out
here we'll keep going.
in 4, 5, V4, V5, V6.
Yeah, I think that's pretty good. It's the same pattern, by the way. Now, ST elevation, again, it's kind of hard. We know the J points here. It's kind of hard to see the other J points here. But I would have no trouble calling this an inferior STEMI because even though the ST elevation is hard to read there, what have we got that's just popping out of the page and telling us, oh yeah, this is an inferior STEMI? What's our additional evidence here that's really solid? Say again?
Hyperacute T.
Yeah, hyperacute T's, and what else?
Reciprocal changes.
Yeah, so the same
And
pattern,
symptomatic.
yeah, so no problem with inferior STEMI, also possible posterior, but let's look a little more closely at V4, V5, V6. Hard to say. I don't think the J point's there, so no ST elevation. I think the J point's there. Hard to say here, although we do have the hyperacute T, but what we do have, it's almost more than straight. It's almost starting to go concave. So this is another one where, oh, that's an area to look at. So what we're going to do now is I was going to do a little blurb about this at the beginning, but I forgot, so I'll do it now. A website that I really rely on and can absolutely recommend highly, maybe not now, but once you're out of, you could even, you could start it now, but you probably need to know a little more about 12 leads to get the most from it, is a website called ECG Weekly. And the guy who is behind it is somebody named Dr. Amal Mattu, A-M-A-L-M-A-T-T-U. And he's kind of he's an emergency physician, and he is sort of a self-described ECG nerd. And what he does, I don't know how he finds the hours of the day, to be honest, because I think he's head of the ED department in the big teaching hospital in Baltimore. Probably University of Maryland, I'm not sure. And he has this output of, every week he sends out a case. We're going to see one so you can see what it's like, where he talks about ECGs and 12 leads, and very much from the perspective of emergency medicine. He's not interested in He's not a cardiologist. It's very sort of down to earth, and you'll see he's a great teacher. So I can't recommend him highly enough. We're going to be seeing a bunch of his videos between now and the end of school. Yeah.
What membership do you have?
Oh, you're looking. So they
It's
just
very
changed.
expensive.
They just changed the membership, and thank you for asking that. So the more expensive memberships they haven't had until about a month ago. The $25 a year membership is gold. You can get not only do you get the cases every week, and you'll see some examples here, but they've got the cases that go back years and years, so many cases indexed, and they're available. So, I use them all the time. I say, oh, let me teach you about T waves this week. Let's see what, I'm allowed to say about T waves. So I can't recommend him highly enough. The other thing about him, he also does conferences. Sometimes they're online. I've done those. Those are great. He also has a course that is expensive that's terrific, but you don't want to do till somebody else is paying the fee for you. When you're working somewhere. But it doesn't matter. It's like $400 or $500. But you can get as much information from the cases. It's just that it's a little more concise. The other thing, he is always saying, email me with questions. And I've done that many times. I'll say, okay, he said so. So, in fact, sometimes students have asked in class, and I think, I guess I'll go to the expert. And not only does he answer, but every single time he is answered within 12 hours. How does he do that? I have no idea. So anyway. So here's an example of his. We'll do this, and then we'll take a break.
He has some really awesome videos on YouTube
Yes.
as well.
Yep, he does. Absolutely.
But my thanks
Oh,
to this physician.
oh shoot. Okay, I'm starting 3 minutes in. Because the 3 minutes of introduction are not worthwhile. But he's saying thanks to this doctor that his format is he usually gets sent 12 leads from other doctors and they send the case and everything, and then he talks about it.
But my thanks
Case 1.
to this physician for sending me this case, and we're actually going to go through a few cases to highlight the key topic for this week. This is a 70-year-old woman that she was taking care of, who presented with chest pain that was radiating to the jaw and shoulders, along with nausea, so this is obviously a concerning presentation. Upon arrival, the patient actually looked fairly well, and the ECG was done while she was initially being triaged, and her pain was fairly mild. Here's the 12-lead ECG. You can hit your pause button and see if you can pick up anything. Overall, I have to say that this is a fairly unremarkable 12-lead ECG. The computer's calling the sinus bradycardia otherwise normal, but during the course of the evaluation, she actually started looking and feeling a bit worse. So what do you do when somebody's symptoms are getting worse? Well, of course, you know by now, if you've been a regular listener and viewer of the videocast, you've got to repeat the 12-lead ECG. You get another one. When symptoms change, when symptoms get worse, when symptoms go away, when anything changes, it oftentimes can be relatively high yield to get a repeat 12-lead. That's exactly what Marilyn did. She got a repeat 12-lead ECG, and here's the repeat. Now, I'm going to put both of these up side by side, but I do want to highlight the fact that the computer is reading the same exact interpretation. Take a look. At the top was with mild pain, and then during Marilyn's evaluation, with patient having increased pain, she repeated the 12-lead. And there's a subtle but very definite change that the computer totally missed. Hopefully many of you are picking up on it. You'll notice, maybe in V2, when you look out there in V2, that there's a little bit of sagging of the ST segment. That's new. And maybe even out in V1, there's just a little bit of sagging. But the major abnormality that we want to focus on this week, take a look at those inferior leads. When you look at the inferior leads, you'll notice that there is straightening on the initial part of that T wave. We've talked about that before. When you see straightening on the initial part of the T wave, you've got to worry. Let me move up and see what it looked like before. Yeah, before it was nice and concave upwards. That's normal. But when it goes straight, you've got to worry worried that that's early cardiac ischemia. Marilyn picked up on that. She ended up giving the patient aspirin, even started heparin. Shortly thereafter, the initial troponin was 391. She set up transfer to the cath facility for stenting. Right before the patient got transferred, another troponin got sent off. It was up to 510, and I don't know the units, but who cares? It's clearly rising. Patient goes over to the cath center and had excellent treatment. I believe ended up getting stented, and peak troponin ended up being 1330. And what Marilyn picked up on was a very, very subtle change in the T-wave morphology. And that's what we want to talk about this week. The concept of hyperacute T-waves. Key point number one, however, just as another reminder, when symptoms are changed, you get a repeat 12 lead, but the major point for this week I want to talk about is this concept of hyperacute T-waves. Most people think about hyperacute T-waves as T-waves that are very tall. For example, if you have a T-wave that's very large, I've talked about that before. When the T-wave gets very large to the point that you can take that entire QRS complex and fit it inside the T-wave, that is very abnormal. That's too tall of a T-wave, and most people think of that as being hyperacute, and I agree. So, first type of hyperacute T-wave you're on the lookout for, if the T-wave is ever larger than the entire QRS, from top to bottom, if you can take that entire QRS and fit it inside the T-wave, that is ischemia until proven otherwise. As soon as ischemia, get your serial ECGs. But the other type of hyperacute is when the initial part of the T-wave becomes very straight, as you're seeing up here. Normally, the initial part of the T-wave is nice, gentle, concave upwards like this, but when it becomes very straight, when you see straightening, even if the T-wave is not tall, you've got to really worry that that's early cardiac ischemia. Those are the two types of hyperacute T-waves that I like looking for, and that I think it's worth you all looking for as well. Let's go on, and of course, the other point I've got to make, I can't forget, don't count on your computer to diagnose this. I've never seen any ECG computer reliably pick up either type of hyperacute T-wave. If it's profoundly abnormal, profoundly tall, that first type, maybe the computer's going to pick it up, but in many, many cases, all too many cases, your computer is not there to help you out. Let's do another case. This was sent by a good friend Todd Haber and one of his colleagues, Dr. Stephen Gugino, who worked down at a very busy emergency department in Lakeland Regional Hospital in Central Florida, not too far from Orlando and Tampa Bay. The 45-year-old man comes in with chest pain. Let's just go right to the ECG. Here's the initial ECG. And again, looking at this, well, there's nothing really jumping out at me, hopefully not jumping out at you either, unless I'm missing something, that's saying this is abnormal. Now, there's maybe a larger S wave in V6 than I would expect. Maybe the leads were placed incorrectly. We've talked about very tall T waves. I don't see any T waves that are larger than the QRS complex here. So that first type of hyperacute is not seen here. Now, I don't see any straightening. Even if you look over here, this is concave upwards, and I'm okay with that. I'm okay seeing concave upwards everywhere. There's maybe just a tad bit of J-point elevation right up there. You're allowed to have 1 or 2 millimeters of J-point elevation in V2 and V3. So why are we even talking about this case? Well, what happened is, a few minutes later, the pain's getting worse, and what do? We repeat the 12-lead, symptoms are worsening. So here's the repeat. Just a couple of minutes later, maybe 3 minutes later, I use the word few to refer to 3. All right, 3 minutes later, the pain's getting a little bit worse, and here's the 12-lead. It's a really subtle change. Let's see if anyone can pick up on it on this repeat 12. All right, so maybe not quite so subtle after all. This is about as classic of the first type of hyperacute as you could possibly imagine, especially out there in V2. You could take that entire QRS and fit it underneath the tent of that T-wave. That is abnormal until proven otherwise, especially in a person with worsening chest pain. You've got an abnormal looking T-wave in V3. This T-wave is not larger than the QRS, but the fact that it's grown larger compared to the first one is definitely concerning. So you can compare the two, and you clearly see that the T-waves have gotten larger. T-wave in V4 has gotten larger. T-wave in V5 has gotten a little bit larger. I'll go back again. Here was the first ECG that we talked about. So take a look at those T-waves. You clearly see that the T-waves have gotten a lot larger in multiple leads. And also in V1, there's this thing that I like referring to as the NTT V1, the new tall T in V1. This is something that I learned from reading some of Marriott's work. What he said was that in a normal patient, let's go back to the previous ECG and take a look at that. That's a pretty normal T-wave progression across the precordium. Normally the T-wave in V1 is flat or inverted, but sometimes it can be a little bit upright. You're allowed to have a slightly upright T-wave in V1, but if the T-wave in V1 is larger than the upright T-wave in V6, that's abnormal. In this first ECG, we're okay with that, but take a look. When the patient's pain worsened, now the T-wave in V1 is clearly larger than the T-wave in V6. The new tall T-wave in V1, that's too tall. When the T-wave in V1 gets very tall like that, that's essentially a hyperacute T-wave, and that predicted exactly what this patient had. These V1 and V2 are the most profoundly abnormal to me, but as we mentioned, V3 and V4, the T-waves have grown also. This patient had a big LAD occlusion. This patient had that type 1, I'll just refer to it as type 1 hyperacute T-wave, where the QRS complex was maybe about that big, and the T-wave was really, really big. And if you can take the entire QRS and fit it into the T-wave, that is early ischemia until proven otherwise. They didn't even wait. They just did cath lab activation right off the bat, and that was 100% LAD occlusion. So kudos to them for saving a life. Case number 3, this was sent by Dr. Scott Winott, I believe that's how you pronounce his last name, from Cleveland Clinic, Akron General Hospital. Scott was actually working in the hospital, and he was actually suturing somebody's face. And I think it was single coverage, so he's busy during night shift suturing someone's face. There's not a whole lot else you can do when you're in the middle of that. Many of you have been in that scenario where you're single coverage, you're the only person there. A 59-year-old guy comes in with some mild chest pain, and they get a quick 12 lead, and you've got to show it to the ED attending. So he's gowned and gloved, he's using sterile technique, and they just show him this 12 lead ECG so he can at least mentally or verbally sign off on this 12 lead. And while he's suturing, he just glances up and looks at this 12 lead, and he says, no, this is not normal. The ECG machine is saying it's pretty normal, maybe evidence of
Which lead?
an
Which
old
lead?
lateral MI, maybe, but it certainly is not calling anything acutely abnormal. But Scott took a look at this
Which one?
and said, well, you know what? These T-waves are hyperacute. This is a little bit more straight than I'm happy with. That's a little more straight. That's a little bit too straight. And also, if you look at this, the T-wave is larger than the entire QRS. So Scott, right off the bat, said, this is early ischemia. So they put the patient back in the room. He says, get me another ECG. And they take the patient into the room, repeat the 12 lead. About 5 or 10 minutes later, he's done suturing, and he walks into the room just as they're finishing up the second ECG, literally 8 minutes after this first ECG. And here's the repeat 12 lead ECG 8 minutes later. And now the STs are starting to rise in V2, ST elevation, V3, ST elevation in V4. Maybe the T-wave's gotten a little taller. There's a little bit of elevation out there, maybe in V5 as well. And now the computer is appropriately calling this an anterior STEMI. And the patient ended up going for a cath and had a 100% LAD occlusion. So Scott picked this up. He was able to make this diagnosis without using his hands because they were gowned and gloved and using sterile technique suturing. All you need is your eyes and a little bit of scrutiny of that 12-lead ECG. So there's another life saving. I'll finish up with one more. This was sent to me by one of our senior emergency medicine pediatric residents, Dr. Carmen Avendano. She's heading back to the Midwest where she's from. It's just a fantastic senior resident. She just recently finished our residency program, so she's not a resident anymore, and she nailed this diagnosis. This is a patient that she was taking care of during her senior year of residency. A 57-year-old woman came in and was having some chest pain, and there's the 12 lead. We don't even need to go through the history here. You see what the eventual diagnosis was. But Carmen picked up on these hyperacute T waves. Take a look up here. And this T wave is too large. You can take that entire QRS and fit it right inside the T wave. That is too large. And also it's looking maybe a little bit too straight out there as well, very straight. But those are huge T waves. What's the computer calling this? Early repolarization. Absolutely, positively not. You shouldn't be calling early repolarization in a slightly older woman, maybe a young man, but 57-year-old woman, you've got to have a lot of guts to be calling this early repolarization. That's not the correct answer. And you shouldn't be calling early repolarization when you've got these gigantic T's also. This was 100% LED occlusion. She didn't believe the computer. She sent the patient right up to the cath lab. And there is yet another life saved by knowing about the hyperacute T waves and not paying attention to your computer. All right, so let's bring things home. Remember, hyperacute T waves, everybody's heard the term before. I would suggest to you that there are two types. What I refer to as type 1, and it doesn't matter which one you call the first type or second type. The one that I refer to as type 1 is when the T wave is much larger, significantly or clearly larger than the QRS complex. If you can take that QRS and fit it inside the T wave, then you've got to worry about early ischemia. And then the other type has nothing to do with the size of that T wave. It has to do with the morphology. When the initial part of the T wave is very straight, even if it's not that tall, when you see very straight like that, that should be considered abnormal. Until proven otherwise, that's early cardiac ischemia. And then the final couple of points, again, you can't expect the computer to diagnose these. I've never seen computers reliably pick up either of these types of hyperacute T waves. And when in doubt, or when the symptoms are changing, get your serial ECGs, and oftentimes those repeat ECGs are going to save a life for you. All right, folks, well...
Okay, so let's take it's 9:35. Let's come back at 9:45. Are there any questions about that before we go?
If you're seeing early ischemia, are you gonna, is that like a cardiac alert?
Oh, okay, good question. What do you do? Well, I'll throw it back at you all. What do you think you do? Let's say you see, I'm not looking at it now, but let's say you have a 12 lead where you see these hyperacute T's, but not enough ST elevation, not 2 or more contiguous leads, but the hyperacute T's are in a particular area. What would you do? And the patient signs and symptoms are consistent with ACS. Okay.
With aspirin and nitro?
Excuse me?
Start like your chest pain, so your aspirin and
Sure.
nitro?
Yeah. Do that. But in terms of the question was, do you do a STEMI alert? What logistically? What do you do?
No,
Of
not-
course, you treat them.
Not a STEMI alert, a cardiac alert.
Okay.
It's a cardiac alert.
Yeah, cardiac. If you have that, in not all protocols have cardiac
Okay.
history, but I think the most important thing you can do. So if you have a cardiac alert, you're
That.
golden. That's
Okay.
great. That's a
Covers
great
all of
thing.
bases.
Yeah, but not all systems have that. If you don't have that, number one, absolutely go to the whatever hospital is your cardiac hospital. I think that's duh. You can decide code 1, code 3. There's always, I'll say code 3, because that's easy. And the most important thing that I think with that is to be able to describe it. So if you transmit your 12 leads, again, you're golden. But even if you transmit it, remember, you're depending on that person on the, we always think the person on the other side knows more than we do. And that's not necessarily the case. And even if they know more than you do, it doesn't hurt to point out what you see. Don't discredit yourself. So, and maybe you can't do transmit the 12 lead. So what I would work on, if I were you, is the ability to describe what you're seeing, okay? So if you say in leads, V4, V5, V6, the T waves are larger than the QRS. I believe this to be hyperacute T waves, sign of early ischemia. Okay, so it's a real skill that you should develop to be able to describe what you're seeing. Okay?
Have to have communication.
Okay, now you get till 9:48. Figure it out, but I apologize, I should have told you that it was coming. That's concave upwards, okay? So when we talk about T waves, a significant finding that we will learn about probably when we do pericarditis, so probably not till next term, is the phrase concave upwards. So if you have a T wave that goes like that, That's concave upwards. Remember, this is concave, this is convex, if we're looking at the top, right? Everybody knows the difference between concave upwards, concave and convex. You ready in the back row there?
Sorry.
Okay.
Not
So when we say concave upwards, that's what we mean. Typically, remember that's as compared to straight or convex upwards, like the tombstone T's, okay? Typically, and if you remember what Dr. Matu said was that whoever was looking at it said, oh, there's no problem because the T waves are concave upwards. And that is a sort of a thing because generally speaking, if your T waves look like that instead of straight or convex, it's a better sign. That being, in fact, people will say concave upwards, that's like a smiley face, you know, it's good. But that being said, you know, there are plenty of stemmings where the T waves are concave upwards, so it's not a definitive thing. But that's what that term means, it's the T wave swoops upwards. The T wave ST segment swoops upwards. Okay. One more case, and I think I've got this one on the handout. Do you have something that says from, well, look. Yeah, this is another great, he's kind of another true expert. I don't recommend him nearly as much, although there's plenty of good stuff on it, because he's a little more fussy. You know, he's a little more, what I love about Dr. Matu is he's very emergency medicine focused, like what is useful. And Dr. Smith, his stuff, even though he's, you know, considered one of the real experts, it's not always as useful. It's interesting, but not always quite as useful. But he had this example, and I really love this because it was a pre-hospital one, so it's the same stuff we're looking at. So 33-year-old female complains of chest pain. 33? Nah, right? But despite the age of the patient and the monitor calling this a normal ECG, a paramedic was concerned about something on the 12 lead. You can either look up here on the one you have in front of it. What was the paramedic concerned about? What do you think? And of course your hint is what we've been doing.
You could fit the QRS and B4 into the T-wave.
Perfect, okay? There's our hyperacute T. So the ECG is the same can fit inside the T wave. So even though everything here points to, oh no, this is not a patient we should be concerned about, this paramedic was, and on the way to the hospital, this again is showing you, yes, you can do ECGs while you're driving. They did. Now, this is over the next 20 minutes. Unfortunately, they X'd out the time, which I'm really sorry, but the whole, you know, it had to be not too many minutes apart. So you can see how it's started to change. And then, okay. So now, meanwhile, on this side, now finally at this point, the monitor is picking it up, and we've got reciprocal changes in the inferior leads and elevation in the high lateral, as well as stuff happening here. Okay, here's number 4.
Okay.
Yes.
Why is that isoelectric line all?
Probably the patient. They probably are driving down the road, right? So there's just a lot of movement in the system right now. But it doesn't. It makes it hard to see, but it doesn't make it hard to see the changes. Yeah.
So that's not really something.
What's that?
That's not something.
No. Oh, I see what you're saying. No. The patient isn't like seizing or anything like that. So, okay. So, and here's the final one. And again, this one was 20 minutes after the start of the one that the monitor was calling normal. And if you compare number 1 to number 5, it's very dramatic. And remember, this is a 33-year-old female. So, I thought that was a really good case. Okay, so moving on. So that's any questions? Yes.
What was the I think you already said, what was the time intervals with all those?
You know, unfortunately, I don't know except
It's a long
the
transplant.
first one to the last one was 20 minutes. That's
Oh.
all I know. And I don't know why. To me, it's the most it's the best thing. I don't know why they X'd out the time. I mean, I know they X'd out I guess so that you couldn't track it back to figure out who the patient
Okay.
was. Yeah. So, yeah, it's too bad they didn't say, but 20 minutes start to finish. Okay, so any questions about hyperacute Ts? Because we're moving on to our next problematic T wave change. Okay, so now we're going to something called Wellens syndrome, which is not terribly common, but on the other hand is easy to see and it's useful. And what Wellens syndrome is, and we're going to see a whole bunch of different examples, is deep inverted symmetrical or biphasic T waves only in V2 through V4, okay? So Wellens syndrome by itself, if all you see is Wellens, and in a minute we'll see what it actually is not a criterion for emergent PCI. Wellens is considered a strong indicator for LAD occlusion. So you can think about it, if you have a patient which is exhibiting signs and symptoms of ACS, and you're looking on the 12 lead and, maybe you don't see STEMI criteria, but you do see something that's considered a strong indicator of LAD occlusion, at the very least, that's going to up your level of suspicion that something is happening or that this is a patient who we pay attention to. It only counts if you see it, and again, we'll see it in a minute, in V2 through V4. You may see it in other leads, but that's not considered Wellens. And it needs to only be in 2. So if you see it in V2, V3, still counts, V3, V4, still counts, etc. Okay, so what am I talking about? There are 2 forms of Wellens syndrome, A and B. I don't care, to be honest, if you don't have to remember which is A and which is B. If you simply look at it and say, that's Wellens syndrome, it's a strong indicator of LAD, that's good enough for me. But keeping A and B, keeping track of them, doesn't matter. So what are we looking at? So Wellens B is deep inverted T waves in V2 through V4. Again, doesn't have to be V2, V3, and V4, just 2 of them. Just V2 and V3 is enough. And you can see how they have this very distinctive look. And even though I said, it's hard to see symmetrical versus asymmetrical, I think this is one where you actually can really see it. These have a very definite look to them. And so, again, what does it matter? Well, so I don't see, I see some sort of worrisome signs here. I don't see STEMI criteria, but if this patient, say, is exhibiting ACS symptoms and this, I might just get moving a little bit faster, be more likely to do serial 12 leads and so forth. Okay, here's another one of Wellens B. You can see it there. Those are really dramatic. And again, it sort of spills over into V5 and V1, but it really, to be called Wellens, it has to be, it's V2 through V4, or two of the 3. Here's another one. And just more examples. Now here's Wellens A. Wellens A, and we've actually had on the quiz, there was one, we didn't know it at the time, but there was one that had Wellens A on it. And what it is biphasic T's. The T, again, in V2 through V4, it goes up and then down, okay? Biphasic T in V2 through V4, same thing. It's an indicator of LAD occlusion, a good indicator of LAD occlusion, and that's what it looks like. So whether it's Wellens A or Wellens B, for our purposes, they mean exactly the same thing. Here's another one. So this one almost looks just like Wellens B, but this is Wellens A. Okay?
So is it important to differentiate that in the field clinically?
A and B?
Yeah.
No.
Okay, just
No, they'll be, to be honest, if you simply say, I have a patient who shows Welland syndrome in V2 and V3, probably the charge nurse will be saying, what's Welland's, what's Welland's?
So it's not like a well-known, and it's not like.
I don't know
read
how
that.
well known. So, it's not very common. The problem is when we say not very common amongst our patients, it's a lot more common than the general population, right? And so, what you could say, I would just call it Welland's, or I might say biphasic T's in V2, V3, and be ready to say, of course, that's a strong indicator of an LAD occlusion. So, okay, now important note here on biphasic T's. Okay, if you think about it, biphasic can mean two things. It can mean up and then down, it can mean down and then up. Both of them are biphasic. This is Welland's, up and then down. This is not Welland's, down and then up. Down and then up is frequently associated with hyperkalemia, which is a whole different thing. But if you see this, don't say, oh my God, it's Welland's. It's up and then down.
So it's just
Now-
like ST elevation to.
It doesn't have to be ST elevation. In fact, what we saw, actually there it is, but it doesn't have to be ST elevation. So in this particular case, we've actually already got a septal anterior stem because there is ST elevation along with the Welland's, but it doesn't have to be if it starts there. Oh, and let me say, if you see ST elevation with Welland's, it's still ST elevation. It's not like we say, oh, it doesn't count because it's with Welland's. Yeah. Andrew, do you have a question?
No.
Okay.
So does the Welland's that's strictly in the precordial leads, specifically 2 to 4?
Yes, so in fact, I'll just go to the next slide, and this might answer your question. Oh, nah, I lost it. Okay, if you see, I'll come back to that, but if you see it in other leads, it's probably not meaningless, but it's not Welland's.
I had a patient in their 20s, probably 2 or 3 weeks ago, that had a biphasic T in just lead 2. It's just
Lead 2?
Yeah, it's just wonky. Yeah, that's
Okay, good enough for me, just wonky. So. Okay, sorry, I seem to have lost my way here.
My favorite medical diagnosis is, this is just some weird thing that happened to you that one time. That's it. I was told that by a doctor one time. It was great.
Yeah. My favorite was I went to a dermatologist because I had, something or another. And he said, oh yeah, it's just a rash.
Thank you.
Am I supposed to pay you for that?
Yeah, there's a medical school. And that's,
Okay, so again, it's very specifically there. In other leads tend to be non-specific finding. When they say non-specific, what that really means is kind of that. Who knows? It's we don't know for sure. Okay. We're going to finish this part with tall peaked T waves. Now, in spring term, I have a whole lecture on hyperkalemia ECG changes. And so we're going to go into it in depth. This is, I thought, we're just going to bring it in so we can, there's a whole bunch of ECG changes that come with hyperkalemia, not just peaked T waves, but peaked T waves, it's the one we all know. I'm just going to bring it in so you can tell the difference between the big hyperacute T waves and the hyperkalemia T waves. So tall, peaked, and they don't have to be tall, by the way, it's more the shape. Tall, peaked, or tented T waves may be a sign of acute hyperkalemia. They're usually more pointed than hyperacute T waves. And also, hyperkalemic patients don't usually have chest pain. Okay? It doesn't quite rule it out, but on the other hand, it's not a common finding with hyperkalemia. Again, we're going to get into all this later on in a month or two. So this is what we're talking about when we say tented. I always think of tented means sort of a sloppy tent. You haven't put it up quite right. And you can see how pointy these are. So one reference I read said, if you're looking at that T wave and you don't want to sit on it, it's hyperkalemia. Okay, so that's easy. So I know it's always a great picture. So compare this to this. These are, and you wouldn't really want to sit on these either, but you can see how they're bulky is always the term used with hyperacute. Okay, so again, here's more hyperkalemia. By the way, there's plenty of hyperkalemic patients who don't have peaked T waves. It's not, if you see it, it tends to indicate hyperkalemia. If you don't see it, you don't say, you're fine, go home, you don't have hyperkalemia, okay? So here's another one. Oh, no, that's number 1. So 1, 2, and 3, it'll take you about 2 minutes, take you about 30 seconds. Look at 1, 2, and 3, say hyperkalemia or hyperacute, okay? Again, it's going to be super easy. It's the second 1, 2, 3. Okay. Riley, number 1.
Huge moment is asked or state if it's hyperacute or hyperkalemia.
Yeah.
I think hyperkalemia.
I think so too. Okay, Kyle, number 2.
Hyperacute.
Okay. And come on, number 3. Excuse me?
Peaked.
Yeah, so hyperkalemia. And interestingly, look at the, T waves are always easier to see in the V leads because they're larger. But look at the limb leads. Even though these aren't really all that large, look how pointy they are. So these also are considered hyperkalemia T waves. Okay. So the next bit, bonus, which means bonus, you don't have to study it. So I'm just putting this in. I'm not expecting you to know this. I mean, there'll be no test questions on it. But I think it's really, really interesting. Is the 12 lead, so somebody experiencing ICP for whatever reason frequently shows really diverse ECG changes, okay? And one of the changes that may occur is the T waves can be larger, broader, and sometimes inverted. So I'm just going to show you some examples. Now, generally, these are people who are unresponsive. So you may or may not do a 12 lead on them. You may be very busy doing other things with this unresponsive female that you're, going code 3 to the hospital with. But if you do a 12 lead, this is something you might see. So it might be useful for you to know, oh yeah, this can happen. You can see in all the leads, these are really broad at the bottom. Like when we talk about QT intervals, it's like huge. And a lot of times they're inverted. So that's there because of the ICP. Here's another example. So again, whether you do a 12 lead on that patient or not, I think it's not useful for you in diagnosing it, because if you've got an unresponsive patient, that's a better that's a better sign than the flipped T waves on the ECG. But just so you know, is this because of the intracranial bleed, the suspected ICP? Yes, that's the answer. Here's another one. Okay. So just to let you know, again, I'm not requiring you to know that. Okay, so it's the end of the section, but we're going to do some practice. So let's take, you can do it, by yourself, with your neighbor, whatever, where it says T-wave practice, and I think it'll probably take, I'm guessing, about 10 minutes or so, okay? So it's 1 through 8. Maybe it won't even take 10 minutes. Maybe it'll take 5 minutes.
I just said it was Wellens.
Okay. And why do we care about Wellens?
possible, or it indicates
You've got a good verb.
an occlusion.
Good. And where? Think of where the leads are. What area is that? What artery would that be?
Oh, lad.
Yes, correct. So so this is Wellens B again. Wellens is fine. You don't even have to say Wellens syndrome. Just Wellens in V2 through V4. So deep inverted T waves. And if you look at this one, there is no STEMI criteria, but if you have this is your patient and they have ACS signs and symptoms, again, you just ratchet up your level of suspicion just a little bit more, knowing that occlusion, when we say occlusion, it's almost certainly not I should say, it's not a full occlusion, it's probably a partial occlusion, because otherwise it would show a STEMI, or almost likely. Okay, Cody, number 2, please. What's most likely? What's the problematic T waves and for what reason?
I'm thinking peaked T's.
Okay, and where?
I'm gonna say V2.
Okay,
Yeah.
where else?
Potentially V1.
Yep. So remember that peaked simply means sharp. I mean, definitely V2, no question. Definitely V1. I included V3 and V4, but certainly V1, V2 are enough. So hyperkalemia T's. Okay. Chris, number 3, please.
I think Wellens in V2, V3 because of the.
Oh, I see what you're saying.
Oh wait, no. I think I have it.
I don't quite, I kind of see what you're saying, but it's
That's a
not
different-
really, it
that's a
doesn't go
different
below the
strip
isoelectric line.
It's a
That's a different strip.
We have a
than I have.
different strip.
Oh, you do?
I
Okay.
think Chris is right though.
On ours.
Okay, well, go ahead and do this one. Let me see, do I have this one any other place? Because it's a great one.
This is a bonus.
Oh, you're right
This is a
about,
great one.
oh, it is.
T-
You're right about Wellens and year 3. But go ahead, what do you see here?
At least in 3 in ABF, hyperacute.
Okay,
Maybe in 2 as well. It's
Okay.
a little close though.
okay. Everybody in agreement with that?
Yeah.
Yeah. Okay, so hyperacute T's in the inferior leads, and here is 18 minutes later. So in this case, it actually did mean an inferior. Look at the changes. We have reciprocal changes in ST elevation. Okay. So let's see. Huh. Okay. Number. I wonder if I just reversed them. Oh, I think what I did was I reversed 3 and 4. Let me see.
McLean Carroll's Whisper.
Dude, I walked in, it was Beastie Boys at first.
Love that.
Okay, so we're going to switch. We're going to skip 4 because that was the one that we just switched them. And Anne, if you could do 5, please.
Okay, so I had hyperacute T's in B2 to B4 from the definition of greater than 10.
Uh-huh. And in V3, what's the other definition that fits?
And it
Yeah.
QRS fits in.
Yeah. And what is that? What's your worry?
That there's going to be a step.
Yeah. Okay. And good. And then make sure it works. Riley, you're number 6.
Alright. I saw that there was hyperacute T's in B4 and B5.
Uh-huh.
The QRS complex within the T wave.
Okay, good.
Um,
What else? That's the answer in terms of T wave, certainly. What else is of concern? Do you think there's a STEMI criteria here?
Yeah, I think from what we're learning that potentially you can see that the, it's like the, sorry, the ST segment's kind of straightening out.
Oh, are you talking about the same area? V4, V5?
I can see it before that as well. I can see it in like V2.
Okay.
Looks a little bit in V2, maybe not V3, but
Okay.
yeah, V4, V5.
Okay, that's a perfectly fine answer. This probably is not quite STEMI criteria. It certainly is. I agreed with you that there are hyperacutes in V4 and V5 and pending STEMI, but I think there's actually, where is there actually an acute STEMI right now? Cody? Yeah, I think I would have no trouble calling this. Again, oh, excuse me, not inferior, that's where the reciprocal changes are. Where's the?
Excuse me.
Yeah,
Oh, lateral.
so high lateral, because we've got all kinds of things here. We've got a little bit of ST elevation in AVL, plus the QRS fits in there. Again, very straightened out T wave here, and then reciprocal changes in 2-3 AVL. So, yeah, but that wasn't what I was asking. So you're exactly right. We also have hyperacutes here. And then number 7, Kyle?
Those are some hyper K peaks T waves.
Yes, they are.
And V3, V2, V3, V4, V5, and 2.
Yeah, pretty much everywhere, right? Yeah, good enough. Okay, and then the final one, number 8, Koa, please.
Deep inverted T waves and precordial leads, and then AVF is concerning because the QRS is the same size as the
Oh,
T.
nice catch. Okay, good. And what are the deep precordial, what do we call those, and what's the significance of it?
You're looking for V2 to V4 for Wellens,
Mhm.
and that's an LED inclusion.
Okay. Yeah, good indicator of. Good. Okay, so one more thing before we finish this. We're still going to do some plain old 12-lead practice, but this part of the lecture will be done. At this point, I'm going to tell you what, again, however works for you is fine. But at this point, if I had to say, well, what strategy would be a good one to follow, knowing what we know at this point, meaning we'll probably change things later, this is what I think is the most useful thing to be doing right now. Begin by collecting your evidence, and even though while we're in class we sort of jump to the conclusions pretty quick, I really think the best way is when you're doing it to go through very methodically and say, oh, lead 1, elevation, and I put an E, lead 2, depression, I put a D, 3, depression, AVL, elevation, and so on. And so you come up with your a picture of your ST elevation and depression, and try to do that without putting it together at that point. Just the facts. What do you see? And then go looking for the T wave changes. So I would look for hyperacute Ts. I would look for Wellens. Certainly, I didn't put it here, but certainly the hyperkalemic Ts. And then at the bottom of all this, not nearly as useful as other things, are the pathologic cues. And then you can put it together. And I feel very strongly that most useful when you're learning, and even when you're not learning, the best way to do it is kind of how we've been doing it, meaning there's a STEMI in this area. I know that because there's ST elevation in these leads, and then there's also reciprocal changes in hyperacute Ts. Because just being able to identify it is really only part of the, part of the important thing. Being able to describe it and communicate what you're seeing. If you can't communicate it, especially if you're working in an area where they don't transmit 12 leads, you're not doing your job. I mean, you have to be able to communicate it. And to communicate it, you have to be able to organize it systematically so you can communicate it. So that's why I put such an emphasis on this is the area, this is the evidence, and so forth. And then finally, as we're going along with the strategy, if there's an inferior STEMI, are we looking, is there evidence for a posterior? Do you need to check for right-sided? And then finally is, and I know we've looked at lots of 12 leads like this, and we're going to continue to do so. There are all these 12 leads that we've seen where we don't, strictly speaking, have STEMI criteria, but are very concerning, okay? That the signs are too subtle, okay? And then that. Okay, so actually, we're